And today we're going to give an overview on the element of mentation. So just as a reminder, the four M's are what matters, medication, mobility, and mentation. Some people like to use or reference mind as opposed to mentation, which is pretty good to use too. And as you can imagine, mentation has several elements to it. So I want to just go over those elements and then focus more on one of the major issues, which is depression in the older adult population. Some people ask, they say, on a medical board question, they will always ask, what's the most frequent mood disorder in the older adult population? And people say, oh, it's got to be depression. But in fact, it's anxiety. Depression is second fiddle to anxiety, but they're both very prevalent in the 65 and older population. So the goals today are to apply assessment and management of mentation in the context of applying the geriatric 4Ms. And in doing so, we want to prevent mood disorder, mentation problems in older adults. We also want to utilize evidence-based tools for assessing mentation. And then we want to talk about both non-pharmacologic and pharmacologic management issues to address any problems that we may discover in the process of our screening process. So I'd like to just go over a case study here. So this is a 67-year-old woman with hypertension, diabetes, hyperlipidemia, coronary artery disease, brought to the emergency room by her daughter for problems of nausea, confusion, fatigue, and loss of appetite. Patient states that she felt sad since her sister passed away 6 weeks ago. She was prescribed fluoxetine by her primary care physician 2 weeks earlier. When examined, the patient was lethargic, only oriented to place and person, and had psychomotor slowing. Blood tests showed a serum sodium level of 124, and usually, well, that's low. So anything under 130 is considered low. So the question is, what's going on here? And I think the question really is, what's causing the patient's problem? So there's a differential diagnosis. She was oriented only times one, so she's only oriented to person, not place and time. So she could potentially have delirium or acute confusional state. Some people have complicated depression, so they more often become agitated. So if this were an hyperactive delirium, then you might think about complicated depression. And then I just recently had a patient with this, the broken heart syndrome. Takotsubo cardiomyopathy is named after a Japanese doctor. And basically it's congestive heart failure with what we call preserved ejection fraction. So the question here is, what's going on? And I just want to point out that this particular patient has grief, and there was hyponatremia induced by the medication. The medication that she was provided, well, all the SSRIs, antidepressants, are notorious for causing hyponatremia. It occurs in about just under 10% of the time. So the other point with this case study is that grief persists in most older adults with loss, and more to the point is complicated grief occurs when there's vegetative symptoms that occur several months after a sentinel event. So when I was instructed on the post grief depression, where grief turns into depression, I was always told there was a 3-month window. And I don't think that's true. I think most people look for symptoms, and we'll talk a little bit about the natural history of grief and the relationship to depression. But I think it's important to point out that some form of grief never really departs. When you lose a loved one, there's always going to be a sense of sadness that will persist by and large for the remainder of your life, and to vary in various degrees. So it's not like this concept that after 3 months everything's back to normal, right? That there is some persistence of symptomatology and sorrow. But again, the complicated grief is when you have things that are represented in this case, which actually the loss of appetite, the low mood, the psychomotor slowing, all that could have been representative of complicated grief, but in fact, it was a medication side effect causing low serum sodium or hyponatremia. So after this case report, I just want to turn to this triad here. We call these the geriatric 3Ds. And I kind of try to make this Venn diagram. I'm not too good at intersecting lines here. I still have to learn these things. But the point being is that, like a Venn diagram, there's overlap between the two. And in fact, sometimes depression is the first symptom seen in dementia. That's why so many people with depression or dementia are treated with SSRIs. It's because they presented with changes in mood as an early manifestation of their dementing illness. And likewise, people with depression can experience delirium, much like we saw in this case of grief. There was overlap with delirium. Now, delirium occurs more often, or is more often recognized in the hospital or nursing home setting. In the community setting, delirium occurs about 1% of the time. So it's not a lot, and that 1% usually ends up in the emergency room. I also want to make the comment that 33% of all delirium currently presenting to emergency rooms across the country is due to COVID. So that's a pretty amazing statistic, I guess. So those 3Ds don't represent everything, right? So there's issue about personal well-being, safety, and stress, emotional stress. Are people feeling threatened? I did a home visit one time in inner city Chicago and found that the 80-year-old grandmother who was actually watching her children was acting a little funny and just not talking right. We later took her to the emergency room, found out that she had somebody had laced one of her coffee or tea, I don't know what it was, with cocaine. So one of the grandchildren thought it was funny to see what grandma looked like when she was high. So safety and stress issues are always of concern in the older adult population. I mentioned anxiety. That's huge. That's the most prevalent issue for mentation in older adults. We briefly touched upon grief. Post-traumatic stress syndrome is important in both older veterans. Back when there were World War II veterans, these are the guys and gals that often didn't express any PTSD. Their expression of PTSD was more in the context of alcohol abuse, but they just wouldn't talk about it. And they always say that, they call them the silent generation. Just as a side note, in the news today on CNN News, I noticed that there's been a new, discovery that the MD, ND compound known as ecstasy apparently is effective in treating PTSD. So who knows where that's going, but doctors may be prescribing ecstasy here before too long. How exciting. And then finally, the point of loneliness and social isolation, which are, two different concepts, but need to be addressed. And as we did a survey recently in our long-term care facility affiliates, where we're providing similar quality improvement presentations, some of the facilities surveyed their residents found about 50% of them felt lonely. Interestingly, there was a small subset that felt that they were very happy being lonely, and so that didn't really bother them too much. And it's a point that I like to make, that sometimes you'll encounter older adults who may have delusions, paranoid ideation. They may hear voices. And my first question to them is, how often does it happen? Are the voices telling you anything? Or if it's music, does it bother you? And about half of the time they'll say, nah, it just comes and goes. It doesn't really bother me. So that gives me an opportunity to think that maybe they don't need medication treatment. But as soon as somebody says, I hear this repetitive song, it comes all, to me all the time, then, somebody may think of delusional behavior and want to treat them with medications that may not be too safe for them, because they're usually antipsychotics. So the goal for reviewing these 3Ds or mentation is to firstly identify, treat, and manage the 3Ds of depression, dementia, and delirium. Implicit in this whole process, and when we screen for these, is that we also want to prevent the 3Ds. And so I think it's really an important consideration that we don't think about all the time. We're looking for what we call screen positive, and not necessarily looking to prevent the depression, dementia, and delirium. So we'll talk a little bit about how we can go about causing, or not causing, but rather preventing these three elements. So providers will ask, so why ask these 4 M's? And again, it prepares the provider to think about a discussion on preventive health care. It also prepares the patient for thinking about prevention. How am I going to prevent dementia? Well, that may lead to the discussion about good blood pressure control, a exercise program, and doing mind exercises. Also, by asking the 4 M's with each clinical encounter, it allows the providers and the patients to update what matters, particularly when circumstances change. One of the things that often doesn't get recognized is the transition from a robust, non-frail state to a frail state. And I probably have mentioned this before, is that no matter when people die, there's typically a 2 to 3 year period of debility that occurs prior to death. Whether you die at the age of 75 or you die at the age of 90, there's going to be 2 to 3 years before then where there's a functional decline. And we often don't recognize it. It's somewhat subtle, but as people progress, and that's why we do the instrumental and daily activities of living to get a sense as to whether they're starting to enter the phase of the premorbid frailty phase. So that, and if so, that may be a point for that third point there about updating what matters to them. And then finally, by asking these 4 M's, we can get a sense of when to transition from a curative solution to palliative care. So we, in the context of assessing these 4 M's, we also do prognosis, You may be familiar with the what's called e-prognosis. So if you Google e-prognosis, it'll take you to the University of San Francisco or University of California, San Francisco website, where they have a repository or an archive of different tools that can help estimate somebody's remaining life expectancy. Of course, there's other programs like University of Chicago where you type in whether you floss your teeth and do a bunch of other stuff, and they tell you how many remaining years of life expectancy you have. And just to share with you a little personal story, so I did that, and I flossed my teeth. So I guess it tells me I'm going to live to age 90, which is wonderful. And then I found out that in my Sanford health chart that they mistakenly put somebody with my name, and I've Googled my name. It's the only name in the world. So apparently there's two Jerviches in the Sanford Health System. One is my real age, and the other one is 88 years old. So who knows what that 88-year-old Jervich is doing, but someday maybe I'll find out. Okay, so as we're screening for the 3Ds, they can be both educational and prep the older adult for better brain health, right? We often talk about how's your heart doing, how's your lungs, everybody's complaining body aches and so forth, but really we don't drill down as to how your brain's working. What is your mind doing, and what can you do to optimize that? So that's where the screening comes in, and you have to have the older adult prepared for that. Excuse me. I thought I was being a good geriatrician when I first got to Fargo, and I was screening, and I think it was a 77-year-old lady who came in for hip pain, and I did the whole shebang. I did her cognitive testing, her depression screening. I mean, I was being a good geriatrician. And at the end of the visit, she says, I don't know why you spend all this time doing all this other stuff. I said, I only came in here for my hip. And of course, she complained about it pretty good to the front desk. And I said, that Dr. Jervich, he's very thorough, but like I only came in here for my hip. So again, preparing people for what you're planning to do, I think is important. Giving them a rationale for why we're doing this type of cognitive screening. So I just want to show here some representative features for each of the 3Ds. So on the left is the mini-cog test, right? So that's, you ask them to remember 3 words: apple, flag, car. They have to be different. You can't say apple, orange, banana. They can't be in the same category. It's like, a couple of years ago, we had our beloved president, say, "Oh, I passed the memory test." I says, "Is male, female, person?" Whoever gave him that test, needed to be taken to the woodshed, because they were all from the same category, and that's easy to remember. But that said, the second element here is the PHQ-2. So that's for depression screening. If you work in a nursing home or long-term care facility, they use PHQ-9. So they'll ask you 9 different questions. So the PHQ-2 is a shortened version of, PDQ version of the PHQ-9. These can, by the way, be self-administered or, a healthcare administered questionnaire. And then finally on the right is the confusion assessment method. So you want to identify the top 2 features, and then either the 3rd or 4th feature to diagnose delirium. And I just wanted to point out on the mini-cog, I included this picture of all these clocks because it really fascinates me. How people do different kind of clocks with neurodegenerative disorders. And I just want to point out that item number 3 here, where you see the trailing numbers on the right side, that's called hemi-neglect. And one of the reasons that we ask people to draw a clock at 10 after 11 is that we want to make sure that both the right and left part of the brain are engaged because somebody could have a, aphasia or apraxia on one side of the brain that you wouldn't detect if you were putting the hands on the same side of the clock. So that's just a point of information there. And then also as a point of information, a positive screen, in other words, somebody who has high likelihood of dementia would score 2 out of 5 points. However, I use 3 as my cutoff because if somebody can't remember 2 words, or if they get one element of the clock screwed up, to me that's kind of representative of potential early cognitive impairment. So I move right on to the St. Louis University Mental Status Test or the SLUMS test if they score 3 or less. All right. So the question then becomes, all right, you get somebody that screens positive, with the mini-cog or not, what do you do if they screen positive? What do you do if they screen negative? So just to break it down, on the left side is if they screen negative, it's a point of discussion about prevention. Okay, so how do you prevent depression? And people don't always think about that. What could lower your mood? What might have an impact? A lot of times, I spoke to a healthcare administrator who just going crazy with the pandemic during the surge, and he said he finally took a week off just to recover, and he said he had no idea as to how badly that had impacted him, going at that pace, that number of hours, and just how it affected his mood. And with a little self-reflection and rejuvenation, he just was really reflecting on the fact that he had to recover. So anyways, that's the whole point of doing prevention. So things like to avoid depression, to do mindfulness, deep breathing. My present for my daughters was an Apple Watch. It keeps telling me to do some deep breathing 4 times a day. I think it helps. And then conversely, if somebody has a screen positive for either cognition, depression, so memory loss, depression, or delirium, you firstly want to think about what the non-pharmacologic interventions might be, and then also what the pharmacologic interventions might be. And sometimes they go hand in hand. Sometimes you can just focus on the non-pharmacologic intervention. So if somebody has early depressive symptoms, and if they're not suicidal, you might consider referring them for CBT, which is cognitive behavioral training, as opposed to prescribing them a pill. So want to just reflect a little bit about how do we prevent those 3 Ds. And so for dementia, the proven interventions are on the left here. Good blood pressure control, mainly not so much with Alzheimer's, but you do prevent vascular dementia. There is some evidence that you do prevent Alzheimer's also. And then exercise is important, and particularly for cardiovascular risks, it's important that we all understand that more is better for exercise. So if you do 30 minutes, that reduces your cardiovascular risk factor by about 10 to 20%. But then if you bump it up to 60 minutes or 90 minutes, you can get fully of 40 to 50% risk reduction for cardiovascular events, so those being heart attacks, strokes, peripheral vascular disease, and dementia. Mind exercises, sometimes we call them mind games, not in a nefarious sense. I was watching the Avengers last night, and one of those Avengers was using mind games to transport Thor into some other world in his brain, to distract him. But the mind exercises typically should be varied. So you want to use visual spatial exercises. You want to do arithmetic type exercises, and just even counting backwards is a form of mental exercise that helps, even with balance. So if you count backwards while you're walking, that's considered dual task training, because you're exercising your brain and your body, and that helps with the older adult better stabilize themselves over time. There's some very strong information about the role of nutrition. And if you hear me long enough, I keep advocating things like turmeric as an anti-inflammatory compound. I had my turmeric this morning in the form of a pill, but usually I grind it up and put it in one of my smoothies. But people who pursue or are pretty adherent to the Mediterranean diet, which is basically fruits, grains, vegetables, and fish, tend to show over a 5-year period less cerebellar or cortical brain atrophy than when compared to omnivores. And then also social engagement is really a huge factor in preventing dementia. And so social networking and things like social networking plus exercise, such as you would see in dancing, really have an additive or synergistic effect. And it's probably not too surprising, but the research on centenarians and 100-year-olds show that they're highly socially engaged, they're fun people to be with, and they don't have dementia. So I guess my prescription has always been, you have to laugh 100 times a day to live 100, and the jokes don't have to be all that good. So just a thought for you there. In terms of preventing delirium, so there are proven interventions. One is don't give Benadryl. Avoid anticholinergics. Benadryl is an anticholinergic. Try to wean any psychoactive prescriptions slowly, particularly if somebody's on a higher dose and the longer you've been on a psychoactive medication, the more likely you're going to be dependent upon it. So things like benzodiazepines, people say, oh, I'm taking Ambien, it's not that strong, and it's for my sleep. Ambien within 30 minutes can cause an older adult to weave like a drunken sailor. Okay, so you can only imagine somebody taking Ambien, in 30 minutes lying in bed when their volume recirculates and they've got to go urinate. They're a high risk for falls. So that's one of the issues, and they can be associated with delirium. Hydration status is important, particularly for the cognitively impaired patient. They don't remember to drink water. I mean, they may swear they drink 6 glasses of water a day, but you just look at their dry mouth and their poor skin turgor, which, by the way, clinically, you always use the pinch test, to look for tenting. That should be done on the forehead and not so much on the forearm. So I see that mistake often made by medical students. They go, oh, the patient's got skin tenting, particularly with the frail older adult. Skin tenting will be found on the forearm, but not so much on the forehead. The other part is reorienting the older adult to prevent delirium. So low levels of light in the hospital are helpful. It's also important to make sure that they're pain-free, comfortable, because pain itself can induce delirium. And then also to support good sleep hygiene. Some people advocate a glass of warm milk. I don't know if that works so much, but those are some examples. Excuse me. And then likely what prevents delirium is mobilizing the older adult as best possible, again, in a pain-free manner. To prevent depression, there are some proven interventions, such as lifestyle. We talked about mindfulness, deep breathing, meditation. I mentioned cognitive behavioral therapy or psychotherapy, certainly education. So that last point there is that there was a study done, maybe about 5-6 years ago, where they used a self-help manual and people with depressive symptoms, not depression, but depressive symptoms. And then they followed up with 6 clinic phone calls and found out that the progression to depression was markedly reduced. So again, a little earlier intervention, can help prevent major or minor depressive disorders. So I want to get into a little bit deeper here, a little deeper dive into depression and talk about its epidemiology, get back to this issue of grief versus depression and the screening and management process. So you have risk for depression if you're sedentary, obese, have alcohol abuse, and you're a smoker. Interestingly, low vitamin D levels predispose you to depression. And again, I have to share with you a story. I had a geriatric fellow back when I was in Chicago who I gave a talk on vitamin D and its benefits. And he came back a week later. He says, I started taking vitamin D and I'm not depressed anymore. So I thought, well, that's pretty good. Maybe it was a placebo, but he swore that he felt 100 times better. And we never measured his vitamin D, so we don't know for sure. But he was an instant convert to the merits of vitamin D. Also, traumatic brain injury predisposes people to depression, as well as being a caregiver, right? So that's the most frequent cause of depression is lack of respite care, lack of family support, lack of taking time off to recuperate from your caregiver stress. So depression occurs in about basically 1 out of 4. It's for men and women. So a little bit higher in women. And remarkably, 85% of these depressed individuals do not get any medical help whatsoever. And isn't that really the best representation of this reproduction here of Winslow Homer's boat in the storm? And you can see that this poor sailor with his broken mast on the boat is being surrounded by sharks who are ready to feast, and it just looks like a hopeless, sad event. And so Winslow Homer, actually, when he displayed this painting, people were so upset with the destitute and the sadness of the situation that he took the painting down. And then you can see in the upper left-hand corner, there's a little wisp of a steamboat with the hope that maybe the steamboat will find this sailor and rescue him. So again, it's just kind of within art, we can see some of the emotions that are expressed, including sadness and depression. So there's 2 kinds. There's a minor depression, major depression. So it depends on the setting, but even with depressive symptoms, you get people using a lot of health services, a lot of disability. They have poorer health outcomes and a higher mortality. So that's right, basically right across the board. And then by comparison, a more major depressive order, these are ones with more vegetative symptoms. The minor depressions are the people that are going around and just, kind of sad sacks, basically. But the major depressive disorders, these are the people that are don't get out. They're sitting, sulking at home. And avoid social interactions, withdrawn, not eating, and so forth. These individuals, represent different proportions. So the more likely you're hospitalized or in a nursing home setting, the more likely you're going to have depression. So one of the important points that we need to convey is that late life depression has, like all other conditions in late life, have atypical manifestations. So weight loss, fatigue is really a huge concern. And interestingly, fatigue is also represented by frailty. So sometimes you'll have a frail older adult and they say, I feel tired all the time. But the point being is that there are a lot of somatic symptoms, a lot of body aches. When somebody tells me they hurt all over, I start thinking depression. Because that's very different than saying, my shoulder hurts me or my low back hurts me, and where they can point with one finger where it is. But if they start going particularly if they say, I don't know, I just hurt all over, that to me is a signal that they're having somatic symptomatology and probably associated with depression. And then finally, prolonged bereavement can be part of that late life depression. So turning towards bereavement, there's 3 stages. First, there's the numbness, like nothing, like, did this really happen? And then that segues into depression. That can occur from weeks to, like I say, typical average is 3 months, but it can be associated for fully up to 1 year. And then there's a recovery period. Again, the recovery may not be full recovery in a sense, but rather a different, less depressed status. And there's a book here from a while ago, but it's called Bereavement, that I just use as a citation. So the bereavement symptoms, and there's no male or female differences, interestingly, between this, but they do have depressed mood issues, a lot of sleep disturbances, can't get to sleep or maintain their sleep. They may have crying jags. Interestingly, I was interviewed by a news reporter from the Chicago Sun-Times, and he says, as men approach middle age, do they cry more? And I thought about it, and I said, I wasn't aware of that. I said, I don't think that there were any studies that show that crying spells increases with male aging. And I said, I was more concerned about whether there was some other intervening process, such as loss of work or loss of satisfaction of work or family, midlife crisis that's, progressed or whatever. But then I had another geriatric colleague say, oh yeah, old men cry all the time. So I think the verdict is still out there. And again, the bereavement can be a loss of appetite. You'll see people become more sallow and they look thinner. They may have a sense of nervousness, just jittery. They don't want to be around people. And so poor concentration, poor memory. They may be, misplacing their keys, for example, and then there's concern about whether they're having dementia when in fact they're having depressive symptoms. So just remember, a lot of things that look like they could be dementia might be related to depression. So that's why we do these different screening tests and try and get at the bottom of identifying whether the cognitive impairment is due to a dementing illness or due to something like bereavement. So here's the progression of depression that's associated with bereavement. So you can see about 40% of people by 1 month have depressive symptoms, but then by the time at the end of 1 year, that's down to 15%. And then by 2 years, it's just around 5%, 5 to 6%. So the point being is that you're still going to have some residual people with sustained depression that's going to need to be treated, either again non-pharmacologically or with some medication. So the persistent depression post grief is typically in a young old, right? These are kind of 55 to 65-year-olds, not so much in the 80 to 90-year-olds. And then the recommendation is to start considering depression with grief beyond 2 months. I tend to use 3 months. And again, I use the balance of other symptomatology. And the other risk factor is that if they were depressed in the past and had not maintained their treatment, then they're at risk for grief-induced depression. So one of the ways as healthcare workers is how do we communicate with somebody who's lost a loved one. And so I think probably most importantly is to have the individual tell their story of their loss. What was their closeness, what was important to them, and then to reflect about positive memories. What were the good times, that you remember, and then try to identify the functional changes, like how are things different now. I have a close friend who lost his wife to cancer, and his reflection is that there's not enough hours in the day for him to do all the things that his wife did, keeping the house in order, the finances and so forth. And so that's how he sees it as being different. And then the other point is, what's your infrastructure? How do you get through the day? Do you have a social support system? And then finally, to ask how the loss has impacted your resources. So, for example, I had a lady who was a patient of mine who lost her husband's pension. So it's basically the pension was terminated, and so she had no source of income, and so we had to hook her up with social work and get a family meeting to reconstitute some level of support for her. In terms of complicated grief, as I mentioned, after about a year, you're going to get about 5 to 7%, I should say, of individuals that are bereaved that have complicated grief. They have weird thoughts. They're maladaptive. They show a lot of dysfunctional behavior, very emotional, very labile. And so these are all indicators of complicated grief. I mean, they'll just say things that you think they're perhaps having some form of delirium or confusion. So just by comparison, complicated grief as an entity versus depression. The complicated grief is a yearning. I'm going to be with my wife, and shortly they may express sorrow. They're preoccupied with thoughts of the deceased. They may make shrines, and just a lot of repetitive behavior, and just manifests a difficulty accepting the death. I don't understand, why did this occur, and just goes on, just like a cycle over and over again. Whereas depression, by comparison, is more of a depressed mood. They're just anhedonia. They're just not wanting to do a whole lot. So I guess the difference between complicated grief and depression being is that you've got the person who's listless, who's a kind of a bump on the log, so to speak, versus the complicated grief where this person's always kind of just more of a complainer. And I don't mean to belittle this. I mean in terms of my what I'm trying to say, but I'm trying to make a contrast between these two versions. So there was a clinical trial. This was reported in 2016. And I found this picture on the internet. I just thought the husband looked a little, I don't know, nonchalant here for his wedding day. But in any event, the wife is very lovely, though. There were 16 sessions that progressed through taking the history, just checking daily, and providing some education. And then that morphed into a memory session, where you collected photos. This is also done, by the way, as reminiscent therapy in nursing homes and for Alzheimer's disease, which is very, very effective, where you bring in pictures and try to relate with past memories. And then finally, having an imagined conversation with the loved one that passed away. So just like I say, having a conversation, mentally, making that conversation, but also expressing it to the therapist can be very valuable, in terms of resolving some of these grief issues. So this shows the study. There was almost 400 people involved in the study. You can see the age went up to 67. So it's kind of a young old group, you know. And again, complicated grief does occur in the younger old population. So late middle age, early, and you can see that of these, the losses, 1 out of 3 were due to some violent death, either a suicidal or motor vehicle accident. And this basically shows the reduction in the grief score over time. And interestingly, the medication, the SSRIs, did not make any difference between, you can see between the red and the orange line, that there was really no, not much difference. So just moving on to this topic of late life depression, to reemphasize that there's a lot of somatic symptomatology. Typically, I ache all over, and it's more likely that somebody's going to complain of the achiness than they're going to complain of saying, I'm down in the dumps. They're not going to tell you that. So to make this diagnosis, you have to have this anhedonia for at least 2 weeks to be associated with a major depressive disorder. So this is just, again, this bump on a log concept. The person's not doing much of anything. They don't eat. They don't get out. They just sit and vegetate. And particularly if they're losing weight, these are the type of people that might be best managed with electroconvulsive therapy or magnetic therapy. I was always amazed seeing how magnetic therapy works. They take the magnet and pass it over the head. But before they do that, they keep cranking up the magnetic energy until they see your neck muscle twitch. So I'm going like, that sounds pretty powerful to me. Of course, my neck twitches when my wife asks me to take out the garbage, but that's another story. Again, late life depression. It's difficult in the physically ill older adult because you've got so much else going on with them. They have multiple chronic conditions. And so there are these mood disorders that are related to multiple chronic conditions. But again, you can kind of distinguish between late life depression and depression associated with multiple chronic conditions. So generally those people have 5 or more chronic conditions. They typically tend to be the COPDer or the person with congestive heart failure. So back to the screening, I mentioned in the nursing home, they use the 9-item patient health questionnaire. It's about as good as the PHQ-2, and that's why we use the PHQ-2 for screening. But the PHQ-9 is best for those who to identify suicidal ideation. And the other point is that the PHQ-2 is not good for therapy. You have to use the PHQ-9. Let's say if you're starting up a SSRI, you can use this to assess whether the treatment's working or not. So the scoring for the PHQ-9 is listed here. If you score 1 to 4, nothing's happening, so you're good to go. If you score 5 to 9 on the scale, you have mild to moderate depression, and you want to get back to that person. Using non-pharmacologic treatment initially, or if they're already on an antidepressant and showing a score of 5 to 9, you want to see them in about 2 weeks. And then the higher the scores here with major depressive disorders, that's the cutoff. So if somebody scores a 10, you then definitely want to start an antidepressant and then follow up on that. There's also another scale called the Yesovich, or the Geriatric Depression Scale. This actually preceded the PHQ-9, and this is the one that I grew up with when I was becoming a geriatrician. It has 15 items, so it's a little bit longer, but it doesn't really inquire about somatic problems, and so it may miss some of the somatic complaints that an older, depressive older adult may have. And also it doesn't really talk about suicidal ideation like the PHQ-9. So some of the important facts about depression treatment, those that have the major depressive disorder, remember that's a score of 10 or greater on the PHQ-9, half of those are going to respond to the initial antidepressant treatment. And then of that 50%, another third, up to another 50% of the non-responders will respond to another antidepressant. You just switch over, or you add a second antidepressant. And importantly, around half of the patients are going to have a relapse. So a lot of times what happens is you give them 3 months worth of therapy with the antidepressant. They say, I've been feeling pretty good now, I'm going to stop my medicine. And guess what? You know, they relapse. So typically we like to extend the therapy for at least 1 year before we consider discontinuation of the medication. So it's important to consider that that you aggressively treat in the beginning, you know, to affect a positive outcome. So here it says a continuation for an additional 6 months to prevent relapse. I use a year. And then you want to have maintenance treatment to prevent reoccurrence. That maintenance treatment may be cognitive behavioral therapy, or you know, the provider office visits if they're comfortable with evaluating depression and its treatment. Yeah, so this just reemphasizes the try to treat aggressively in the acute phase, and just what I mentioned here. So it turns out that the first 4 weeks are really key to who's going to respond after 3 months of treatment. So at that 4 weeks, you're going to have 33% will not be responsive, a third will have responded, and then another third will be sort of in between. You know, they kind of partially responded. So in order to use as an adjunct or adjuvant for synergizing with the medication, you really want to tie this into some follow-up phone calls or a visit. So we need to consider what the distribution of antidepressants are. Just suffice it to say that the first one, the SSRIs, the selective serotonergic reuptake inhibitors, are the preferred medication. It turns out the noradrenergic reuptake inhibitors have way too much sympathetic activity and can really make the person quite jittery. These are just basically doses and concerns. I particularly like to use citalopram or escitalopram because they are, if they're going to work pretty quickly, whereas sertraline may take 4 to 6 weeks before you know if it's going to have a response. The main side effects to remember are QT prolongation and hyponatremia, that low sodium. Yeah, so that just reemphasizes that you know, you can get up to well, up to 4% hyponatremia with some of these medications. The other side effects is that the antidepressants increase your risk of falls along with fractures, and basically the odds ratio is almost twice for people on these medications to get fragility fractures. So not great, you know, but you still have to treat the depression, but just recognizing that you might have to have a concomitant exercise and fall prevention program going on when you prescribe these medications. So they have side effects. It's called the serotonin syndrome. They can become hyperactive. They may be confused. Typically, they're going to be diaphoretic. They may have bowel symptoms and fever. So those are the main ones. And then you can see some of the other side effects from serotonergic syndrome. This requires hospitalization. All right, so I think we're at the time here. I was going to launch into traumatic brain injury, but I think what I'm going to do is save this for our next session when we talk about mentation. We didn't really talk, about delirium management. We didn't talk about dementia management or traumatic brain injury, nor did we talk about anxiety.